So good afternoon, everybody, and a very warm welcome to the European Achondroplasia Forum workshop on understanding sleep studies in achondroplasia. So today, this is our 6th workshop in this highly successful series, and we are delighted to have 112 delegates registered to join us today, which is brilliant. We have a great programme, which will be chaired by Professor Brigitte Fauroux, a specialist in this area and a member of the EAF Steering Committee. So welcome to everybody. So next slide, please, Kate. Okay, so before we start today, we'd like to cover a few points of housekeeping to ensure that the afternoon runs as smoothly as possible. So the meeting is being recorded and will be shared on our website. We recommend your camera is turned on, but ask that you mute yourself during the presentations. If there is any background noise, we may mute your line, but then please feel free to unmute yourself then when you are taking part or speaking. So please hide non-video participants and feel free to share your thoughts at any time and using the raise hand in the reactions to indicate your wish to speak. So during the programme today, you will have a number of opportunities to take part in some polls and quizzes. We want to make this meeting as interactive as possible, so we really want to encourage you to take part, as these events always benefit greatly from audience participation. Your feedback on the workshop is also invaluable to us in planning future EAF events. If you need to leave the workshop before the meeting closes, we will email you a link to the evaluation form. If you attend the full meeting and are still online when we close the meeting, this form will pop up automatically for you to complete. And please give us as much feedback as possible. We really do appreciate it. So the events team from CSAS Medical, including myself, Kate Spittle, will be facilitating the workshop today, and we will be available throughout the whole of the meeting to help with any technical problems if needed. So please message us in the chat function if you need any help. So moving swiftly on to the programme this afternoon, so it's my great pleasure to hand over to Professor Fauroux to start our workshop today, which we really hope you enjoy, and thank you for joining us. Over to you. Thank you, Brigitte.
Thank you very much. So I would like first to thank our sponsors, Ascendus, Biomarin, Quet Therapeutics and Sanofi for helping us to organize this workshop. Next slide. So here you have the objective of this workshop. It's to describe the different types of sleep disordered breathing, to look also at the different studies necessary for the diagnosis and treatment, to discuss also the screening and the therapeutic options, and at the end develop guiding principles of care for sleep disordered breathing in achondroplasia. Next slide, please. So I have the pleasure to make this workshop with Joseph Millerad from the Karolinska Institute and the Astrid Lindgren Children's Hospital from Sweden, Mieke Boon from the University Hospital Leuven, Belgium, Nuria Madureira from the Pediatric University Hospital from Cumbria, Portugal, and finally Lino Nobili from the Child Neuropsychiatric Unit from the University of Genoa in Italy. Next slide, please. So we will see first the sleep studies and then have a break before dealing with the therapeutic options and finishing with a summary and closing remarks. Next slide, please. So first, I will start with understanding sleep disordered breathing in achondroplasia. Next slide, please. So first, within this workshop, we did a pre-mating survey where there were respondents from a large range of specialties and countries, as is depicted here. So there were pediatricians, pediatric endocrinologists, pulmonologists, genetists, somnologists, ENT surgeons, family doctors from several European and non-European countries. Next slide, please. So the first question was, is there a multidisciplinary team in your center? And you can see that most of the respondents responded yes, and there were only 2 centers who responded no, who was a university hospital in Germany and Iraq. Next slide, please. Then we asked the questions, which guidelines do you follow for monitoring of sleep disordered breathing in achondroplasia? So the majority responded that they used both international consensus and recommendation and APP guidelines. Next slide, please. Also, we had a question on the facility needed to carry out routine screening for sleep disordered breathing. So most respondents responded yes. There were only 3 who responded no, and 1 who didn't know about the facility needed to routine screening. Next slide, please. So there is the first poll: is it essential that centers managing achondroplasia have access to facilities to assess sleep disordered breathing, either within their own center or, sorry, I can't finish my sentence. So the first question is yes or no. So please vote. So you vote yes or no. And the so yes, 100%. So I think there is a total agreement about this first poll. Next slide. So the first is that we will see together the understanding of sleep disordered breathing in achondroplasia. Next slide, please. So there are 3 types of sleep disordered breathing: obstructive sleep apnea, central sleep apnea, and alveolar hyperventilation. Next slide. So the most common sleep disordered breathing is obstructive sleep apnea, which is characterized by repeated obstructions of the upper airways during sleep. And we speak about hypopnea if the airflow is reduced more than 30% of baseline airflow, and apnea when the airflow is reduced more than 90% of the baseline airflow. Next slide. So here you see normal breathing, where you see that the airflow is particularly regular with... Sorry, is there a problem?
No, I think someone just had their microphone off, Brigitte. Please carry on.
Okay. So you see also synchronous movements of the thorax and the abdomen. Next slide. So here you see the representation of an obstructive sleep apnea, where you see that there is in total interruption of the airflow of the sound with an paradoxical opposition phase movement of the thorax and the abdomen, which signifies a respiratory effort. Next slide. So the OSA severity is based on the apnea-hypopnea index with different threshold for children and for adults. You see that the criteria to determine mild, moderate, or severe obstructive sleep apnea are much lower for children as compared to adults. Next slide. So there are different causes of obstructive sleep apnea in achondroplasia. You see in red the bone factors which are characteristic of achondroplasia, because these patients have maxillomandibular retrusion or hypoplasia, and also mid-facial hypoplasia. These patients can also have obstruction related to hypertrophy of the adenoids and the tonsils, and in adolescents or older children, lingual tonsils, as can be observed in healthy, normal controls. Also, we know that overweight and obesity are risk factors in patients with achondroplasia, and that both overweight and obesity are also risk factors for obstructive sleep apnea. Next slide, please. So here to show an interesting study where they analyzed the craniofacial growth and function in 15 children with achondroplasia. They performed two-dimensional and three-dimensional CT scans, and they showed that all the patients had maxillozygomatic retrusion, nasal bone hypoplasia, and convexity of the forehead. Next slide. And also, when they analyzed these different factors according to the age of the children, they observed that from newborn until the age of 12 years, there was a progressive aggravation both of the skull deformation and of the mandible deformation. So these bone abnormalities does not improve with age, but they get worse with age. Next slide. Also, they showed here that these bone abnormalities correlated with the severity of the apnea-hypopnea index and the obstructive apnea-hypopnea index, explaining that the obstructive sleep apnea is present in all age groups in children with achondroplasia, either even if they are operated, ENT surgery or not. Next slide. So here you see the symptoms that were reported by parents of children with sleep disordered breathing. So the most common clinical symptoms was snoring, followed by night sweats and witnessed apnea. Next slide. However, these symptoms are not correlated to the objective results of the respiratory sleep studies, because you can see here that only one patient had a normal sleep study, and that 13% of the children had mild obstructive sleep apnea, 43% moderate, and 43% severe obstructive sleep apnea, as you can see in the red box on the apnea-hypopnea index. Next slide, please. Also, what is important to note is that this obstructive sleep apnea was present even in the children, the 15 children who had prior ENT surgery. So the message here is that previous ENT surgery does not prevent obstructive sleep apnea in children with achondroplasia. Next slide. Here again, you can see that despite previous ENT surgery, there are children in the red box who have mild, moderate, and even severe obstructive sleep apnea. As you can see you can see that 5 of the 7 children with severe obstructive sleep apnea had prior ENT surgery. Next slide. So what is interesting to note is that we observed in our experience, when the children were sufficiently old to have tonsillectomy, we observed a significant decrease in the obstructive apnea-hypopnea index. So you have to wait until the child has sufficiently large tonsils and that you are able to remove 2 tonsils to see an improvement in the obstructive sleep apnea in those children. Next slide. So in conclusion, obstructive sleep apnea is highly prevalent in children with achondroplasia. There is no correlation with symptoms and signs. Previous upper airway surgery does not guarantee the absence of obstructive sleep apnea. Obstructive sleep apnea is often severe and may occur at any age, which justifies systematic sleep studies in this population. Next slide. The second type of sleep disordered breathing is central sleep apnea. Next slide. So you can see here that on the sleep study, the event is completely different, because you can see that the thorax and the abdomen, represented by the green and red tracings, are completely flat. So the patient is not breathing anymore, because the central drive is not giving the signal to the respiratory muscles. Next slide. So sleep disorders, central sleep apnea has been reported in children with achondroplasia. Here is a study of 88 children aged less than 14 years old, and you can see that there are some children who had obstructive sleep apnea with central apneas ranging from 0 to 49. Next slide. Here in this other more recent study, there were 19 out of 114 children who had central sleep apnea on a sleep study. However, in this study, the authors did not give a precise definition of central sleep apnea. What is interesting to see is that most of the children were very young, aged less than 1 year of age. Next slide. Also, in another study where we looked on a 1 year period to all the children in our unit who had central sleep apnea, we had 2 young children aged 4 and 6 with achondroplasia. Of one had an associated Down syndrome. Next slide. Within the context of achondroplasia, central sleep apnea is related to brain stem injury due to cervico-occipital compression. And the pediatric definition of central sleep apnea is a central apnea index of more than 5 events per hour. Next slide. So you can see here, in this study, they analyzed the data of 17 children with achondroplasia who had sleep disordered breathing and foramen magnum stenosis. Next slide. However, they did not observe any correlation between the respiratory disturbance index and the diameter of the foramen magnum. Next slide. So to conclude, there is no validated definition of central sleep apnea taking in account the patient age. This is important because central sleep apnea is physiologic, is normal in very young children, and decreases with age, with an index of 5 being admitted as abnormal in children after the age of 1 year. In achondroplasia, the prevalence of central sleep apnea is low and peaks within the first months of life. Again, there is no correlation with symptoms and signs, and the brainstem injury is the main cause of central sleep apnea, which also justifies systematic sleep studies when risk of cervico-occipital compression is high, so essentially in the first year of life. Next slide. So just to finish on alveolar hypoventilation. Alveolar ventilation is defined by an arterial or surrogate PCO2 more than 50 millimeters of mercury for more than 25% of total sleep time for children. However, the pediatricians don't agree with the definition of the American Academy of Sleep Medicine because this definition is much larger than that retained for adult patients. Next slide. And this definition has not been validated in children, and also not validated against a marker of end organ morbidity. Indeed, we don't know exactly the potential deleterious effects of high levels of PCO2 in children. We don't have enough information on the threshold, the time spent at the CO2 level, and also the median and long-term consequences of high levels of PCO2. That's the reason why different definitions are used in clinical practice. Next slide. Indeed, when you look at the pediatric literature, a lot of different definitions have been used. So when interpreting the studies, you have to take into account the definition. Next slide. So you can see here a progressive increase in CTO2 during the night in one child with achondroplasia. Next slide. Sorry, I can't see, but you can see that there are alveolar hyperventilation is characterized by a high level of PCO2. Next slide. So what is also the more severe the obstructive sleep apnea, the higher the risk of alveolar hyperventilation. As you can see in the red bar, in the range of the obstructive, the severe obstructive sleep apnea. Next slide, please. So the conclusion here also that this hypercapnia while sleeping is related to alveolar hyperventilation and reflects the diminished pulmonary reserve in children with achondroplasia. Next slide. So there is no validated definition. Patients are at risk of hyperventilation because also of the small thorax. Again, no correlation with symptoms and site, and this justifies a systematic recording of transcutaneous CO2 during sleep. Next slide. So in conclusion, sleep disordered breathing is highly prevalent. It may occur at any age, which justifies systematic screening. The different types of sleep disordered breathing are characterized by a different pathophysiology, but the different types of sleep disordered breathing may be associated, and also deciphering the different types of sleep disordered breathing is crucial for an optimal therapeutic management. Next slide. Next slide. So here you have the guiding principles which are within the remit of the European Achondroplasia Forum Guiding Principles of Management. Next slide. So guiding principle 1, due to the high prevalence of sleep disordered breathing in individuals with achondroplasia of all ages and the risk of associated complications, lifelong assessment and proactive management is required. Please share your thoughts on the content and the wording. Let's vote. So do you agree with the guiding principle? Please choose yes or no. And for the level of agreement, 10 is strongly agree and 0, I don't agree at all. Please vote.
So we'll leave the poll open for a little bit longer. We have 22 of 47 participants who voted. So please continue to vote. Okay, we'll give another 5 seconds for anyone that hasn't voted yet. Thanks, Alex.
So for the agreement, 100% yes, but the level of agreement, strongly agree 47 and 9. So I think that 9 and 10 is around 63%. So maybe we have to try to reformulate this principle. Next slide. So Joseph Millerad will speak about which sleep study?
Okay, thank you very much, Professor Fauroux. So I'm ready to share my slides with you. And as you will see, several of my slides will duplicate or replicate what Professor Fauroux have already shown, but I need to elaborate a little bit more on the possible consequences.
All right, Joseph, Joseph, I've given you remote control of the screen, so you should be able to move the slides on.
Well, I'm not. Oh,
there we go.
Here it goes. Okay. So just a brief presentation of myself. I need to get back one slide. It's a little bit slow. All right. So just a brief presentation. My background is actually in pediatric intensive care and neonatology, and the pediatric sleep research unit where I'm working right now started out actually as a follow-up clinic for neonates with chronic lung disease and for children with life-threatening events. And over the years, it has evolved to be a more comprehensive pediatric sleep unit. So that's about it. And I have a little bit problem of finding the buttons. Can I ask you to help me with the slides? All right. Thanks. So this is actually a replica of Professor Fauroux's slide, and it's well-known criteria for sleep-related disturbed breathing, and the definitions of central apneas, obstructive apneas, hypopneas, and also maybe very important, what do we mean by airflow restriction and work of breathing? All these are associated with a decrease in oxygen saturation. That's part of the definition. And I will elaborate on this a little bit more. Are these criteria really perfect for infants and toddlers of all ages, or do we miss something? And one thing that is not part of the glossary is actually not central sleep apnea, but periodic breathing, which is a type of breathing that we see in younger infants that can be completely normal, but it may be mistakenly characterized as repeated sleep apnea, central sleep apnea. I'll get back to that later. Now, next slide. Let's see if nothing happens. Kate, could you help me? All right.
Yeah, I've moved it on. If you say next slide, I'll move on for you.
Yeah, please, if you can help me.
Of course.
So if we summarize, what do we mean by sleep disordered breathing? It's actually two parts. I don't know, if I point with my mouse, can you see where I'm pointing?
No, we won't, but if you give me some guidance, I can try. Okay,
so there are actually two parts of it. The first one is the breathing pattern to the right, if you can point there, which is summarized in apnea hypopnea index. And the other part is actually the actual gas exchange, that is the oxygen and carbon dioxide levels, which you can measure in different ways as a mean oxygen saturation or as a drops in oxygen saturation per hour, which is called the oxygen desaturation index, and also in mean carbon dioxide levels. Very important, as Professor Fauroux has pointed out. Now, do we have normative data for this? I think we do not have. So every lab and most labs do have some normative data depending on the equipment that we used, but I wouldn't say that this is really the truth. In our lab, the apnea-hypopnea index below 5 is not regarded as pathological, but on the other hand, we don't see healthy children where mean oxygen saturation is below 95. It has to be over that. Oh, if you can please get back one slide. Yeah, please stay here. And also, we don't see healthy children that have mean carbon dioxide levels above 6 kilopascals. So if we put all these together, which of these factors are mostly related to adverse outcome, both in terms of physical development and cognitive development? My bias is that it is really oxygenation. If we can take the next slide, please. All right, and this is the rationale why we think that this is the case. If we look at adult or older children where oxygen tension in the blood decreases, what happens then? Well, first of all, respiratory rate goes up, heart rate goes up, and you will become more alert. If you are asleep, you will arouse from sleep. And this is the defense strategy to hypoxemia. However, if we look at the fetus can't escape like we adults have. So the only way for the fetus to respond to low oxygen levels is to save energy and save oxygen, first of all, by redistributing blood flow, but also actually by decreasing all type of muscle activity that consumes oxygen. So muscle activity will go down, temperature will go down, heart rate will go down. And this is the strategy of the fetus to survive the episode rather than to fight it. Now, after birth, there is a transition period. So so very young infants may actually act and react in a similar way that the fetus, and over time, a more adult response develops. And this means, in practical terms, that if an infant will be subjected to hypoxemia, this will actually depress respiration. It will not stimulate ventilation. So the cause and effect may be just the opposite. It's not that hypoxemia is the result of an apnea, but the apnea will be the result of some kind of event that triggers hypoxemia. Next slide, please. Okay, and related to this development after birth, I would just like to point out that even children with achondroplasia, they have similar problems as healthy children. And first of all, that there are other causes of sleep disordered breathing except achondroplasia itself and the face morphology. And in small infants, it's really, if you have a small lung or an immature lung, the oxygen stores will be low, which means that you have to breathe very rapidly to maintain oxygen tension. And if your breathing rate goes down, even if you have very brief respiratory pauses, this will coincide with drops in oxygen saturation. And I will elaborate on this on the next slide. So this is the infants. In toddlers, there is an age span where you have the hypertrophy of lymphatic tissue. So this is really a common cause of sleep disordered breathing and sleep apnea, irrespective if you're a healthy infant or if you're a child with achondroplasia. But what this means really, that if you already are compromised in your breathing patterns, these two factors will add upon what's already present. So infants with achondroplasia will get worse off by this normal developments. Next slide, please. So from this physiological background, back to what screening techniques do we have? And I think most of us do agree that we should screen all infants and children with achondroplasia, both for disordered breathing, but also for gas exchange and oxygenation. If we talk about oxygenation, the most simple tool to screen for oxygenation is pulse oximetry. This is really cheap, it's easy, it's cost efficient, it can be done at home. The problem is, of course, if you have a normal pulse oximetry for 1 or 2 or 3 nights, this, I think, excludes a severe breathing disorder. However, if the recording is not normal, we can't be sure of what this really means, if it's because of artifacts or is it because the child has a sleep disordered breathing. So we have to do something else, and something else will most often be a home sleep polysomnography. I called it here home sleep study, but it is actually a PSG, and there are plenty of devices available that have sensors for EKG, for respiratory movements, for oxygen saturation. And they also have algorithms, so you can analyze breathing patterns to more or less be able to differentiate between obstructive and central sleep apnea, not 100%. The problem here is, of course, that even if this is a simple and reliable device, it's when you have an automated analysis, this may overlook important factors, and it may also exaggerate irregular breathing on the expense of gas exchange. So if we are talking about infants that really need some kind of respiratory support, my advice based on our experience is that you need a more sophisticated equipment to really take into account what needs to be treated if treatment is necessary. Next slide, please. So basically, to put this into 2 categories, what are the advantages and drawbacks of the 2 methods used? First of all, these more simplified devices with simplified home monitoring, that is PSG at home, is, as I already mentioned, that these devices are really made for detection of more simple or uncomplicated types of sleep apnea, either obstructive or central sleep apnea. And as I will show you on the next slide, these simplified recordings, they really overrate the importance of irregular breathing, and they tend to underestimate the respiratory flow restriction and hypercarbia, because some of these devices don't measure carbon dioxide levels. And also, which I already mentioned, there are really no good normative data for different age groups. And often when we talk about children, we take all the children, we lump them together from newborn period up to 3 or 5 years of age. And this is not really correct, as I tried to point out here, because they are different levels of oxygenation, different breathing patterns, and I think different normative values in different age groups. So if we really have to define more severe types of sleep disturbed breathing in both children with achondroplasia and other children, we really need a polysomnography device that is more designed for the diagnostic workup. The drawbacks are evident. First of all, not all institutions do have these techniques. It's quite labor and time consuming compared to home monitoring with automatic analysis. But the other positive thing about the polysomnography techniques that is not homebound but hospital bound, that most sleep labs, they have really collected normative data over a long period of time. So even if my normative data may be not the same as your normative data, we can still say something about the individual infant that is being recorded with our equipment. Next slide, please. So from these more general thoughts about methodology and sleep recording, I would like to point out to what I see as 3 caveats of interpretation. And I already touched upon lung function, and I will show you some sleep recordings that really exemplify this, that as a matter of fact, if you have a low lung function, this may mimic sleep apnea without being sleep apnea. So this cannot be treated as sleep apnea because this is something else. The second thing is, but also in small infants, that if we have an airflow restriction of the kind that Professor Fauroux mentioned, this may really occur even if breathing is quite regular and not disordered. And this is difficult to exemplify with home sleep devices. And finally, the third point that I would like to make, which is really related to both children with achondroplasia and also infants that have some kind of brainstem abnormalities or brainstem problems, is that this leads to an incoordination of inspiratory efforts. So we don't need to have physiological collapse of their upper airways. It's just that the inspiration is not coordinated with the widening of the airway. I'll get to this later. Next slide, please, Kate. Okay, so let's talk about the reduced lung function. The upper baby is, of course, one of those that we have been working with for many days. They have a reduced lung function because they are prematurely born and they may have chronic lung disease. But this is not the only baby that have a reduced lung function and small lungs. The second radiograph, this is of a newborn baby with achondroplasia. And if you look at the thoracic volume compared to the abdominal volume, you can really see the difference. This is not how a healthy baby will look like. So lung volume is, in many cases, reduced in infants with achondroplasia, and clinically you can see that both infants, both the preterm babies and infants with achondroplasia, they have a very high respiratory rate. They have to breathe more frequently and more in order to maintain oxygen saturation. And as soon as the breathing rate decreases without the actual breath being decreased or without a sleep apnea, it may just be a sigh or a very short respiratory pause, you will see a major drop in oxygen saturation. I mean, really deep drop in oxygen saturation that is not really, that has no relation to the respiratory pause. So this is not sleep apnea. This is a deficient oxygen store and a consequence of a small lung function. Next slide, please. Now, this is an example of incoordinated breathing, and I cannot point with my mouse, but what you can see here are the small arrow, red arrows. See, Kate, could you please point at the upper arrow and the lower arrow? If you look really close at the black line to the left of the arrow, you can see that when the abdomen expands, that is, there's an upward flexion of the abdomen line. Can you point at this, Kate? No, it's the one. Yes, that's the upward flexion of the abdomen. There is a downward flexion on the chest, the line above. So what this really is, that when you make a breath, it is not only air that's being sucked in, but the chest is being sucked in, because first of all, because the upper airway may not be really patent, and secondly, because there is no real good coordination between inspiratory efforts. And this is marked both with children with brainstem problems, and also in small infants where airway may not be really patent. And if you point at the big red arrow, Kate, you can see that there is a drop in oxygen saturation over here. And this drop in oxygen saturation, it's really related to that the breathing rate, that is the upward and downward flexion, has been decreased. So there is no sleep apnea. This is not a hypopnea. This is only that if breathing is not efficient and breathing rate decreases, we will have a drop in oxygen saturation. So what should we do with that? It's not really part of the ASM definition. Next slide, please. Now, what I'm showing you here is a sequence of periodic breathing. This is the way that preterm babies really like to breathe. And this is also a type of breathing that we see in young infants most frequently under 1 year of age. This is not sleep apnea. You can see that the breaths are, there's no scale here, but the reason why they are breathing this way is because they take really big and deep breaths. So the respiratory pause is not really a central apnea, it's a it's a respiratory pause after a big breath, or almost after a sigh. And you can see that the oxygen saturation, it's the upper red line, please. That's the one. It flexes a little bit up and down, but it's not really deep falls in oxygen saturation. And at the end of the recording, this breathing all of a sudden stops. Because, again, this is not a pathological condition. This is a way of breathing. And one reason why small children breathe like this is because they need to expand their lungs from time to time. And the best way to expand your lungs is to take a real big breath, and you keep the air in the lungs for some time. So this would be my second point. And the last slide, please. There we go. Oh, yeah, you have to click several more times because this is, here we go. This is an infant with ulnar Chiari malformation, that is a tethered cord. If you can point at the radiograph over there, Kate, you can see the cord coming up to the brain. Yeah, there we go. And the cord is drawn down into foramen magnum, so it actually can produce similar problems as an infant in achondroplasia, although in achondroplasia there is a narrowing of foramen magnum. Here the cord is kind of tethered and drawn down. Now, how does a normal inspiratory effort look like? The first thing, impulse that comes from the brain centers, are that we widen the nose, the nasal prongs are being widened. Then we put the tongue forward by the genioglossus muscle. Third comes the larynx, it widens. Then the intercostals contract, and finally the diaphragm contracts. So this is a very precise step of events to make sure that the airway is completely patent before the diaphragm contracts and the air goes in. Now, one of the first problems that you can see in those infants, which I also try to illustrate, then this very fine motor coordination is lost. So the diaphragm can contract before the genioglossus muscle goes forward, so you can have an airway obstruction at the tongue base levels. The larynx may not widen enough before the intercostals contract, so we have a functional airway construction at the laryngeal level. And I think this is a real challenge for us to see if the activation of inspiratory effort is coordinated or not, because this can be mistaken as if an infant needed an upper airway surgery. They do not, because it's not the size of the upper airways that's the problem. It's the fine motor coordination of inspiratory efforts. I think I put an end here, so I don't take too much time. I have a few extra slides, but I think we'll stop here. Thank you for your attention. And sorry if I have repeated too much of Professor Fauroux's slides.
Thank you very much, Joseph. May I have the next slide? So we had a question: what do you consider to be the optimal method of screening for sleep disordered breathing from birth to 5 years? So there are 3 age ranges: the first months, 1 month to 1 year, and over 5 years. And there are several options possible on the different diagnostic tool we discussed. So the comments were that oximetry could be a good screening test if that patient is asymptomatic, if suspicion of obstructive sleep apnea or hypoventilation. You have to complete with a polysomnography with transcutaneous CO2. Ask for typical symptoms with a low threshold for conducting an overnight sleep study if suspicion of obstructive sleep apnea. And one also, I don't have the expertise to ask this question, which depends on the specialty of the responder. Next slide. Yeah, here we have the same results for older age groups, older children, adolescents, and adults. So you see that there are quite big difference between the respondents. Next slide. If polysomnography or respiratory polography are not available, what testing do you use as an alternative? So most of the audience responded pulse oximetry with transcutaneous carbon dioxide monitoring, and only 4, a minority, with pulse oximetry only. Next slide. So first, the guiding principle. The type of sleep study required to assess for sleep disorder breathing should be individualized to the age, needs, and symptoms of the patient. So before voting, we would like to discuss with you this guiding principle. So among the participants, do you want to discuss or to express your thoughts or a suggestion on this principle? So I think we are a bit short in time, so maybe...
Sorry,
Yeah.
Brigitte, there's a comment from Klaus.
Yeah.
Yeah, maybe I can stress the opinion that it really depends on the quality of the sleep lab, and I think it's if we have seen this from these very important expert centers, I think I cannot really compare it with the usual sleep lab which is available at most centers. So for me, it's really good to have, but at the moment, very often I don't have the quality expert opinion from the lab who investigated this child.
I think that your remark is extremely important, because I think that as somebody who explores achondroplasia children every day, first, it's important to be a pediatric sleep specialist and to know how to score and analyze sleep tracings in an infant, a young child, or an older child. Also, I think it's very important to have expertise in achondroplasia, to know the pathophysiology of the respiratory involvement in achondroplasia, because those patients have facial abnormalities and also a small chest. So you must be aware of that when you are scoring and interpreting sleep studies. Yeah, Kate, can we vote now? So again, first question, do you agree with guiding principle? And then please rate your level of agreement.
Okay, so we have about half the participants have voted so far, so let's keep it open for a little bit longer, please. So we'll just leave another 10 seconds, please, Alex. Thank you.
So 100% agreement, which is excellent. And also we can see that more than 2/3 have a good level of agreement with this guiding principle. So thank you very much. May I have the next slide? So now we will listen to Mieke Boon and Nuria Madurera.
Good afternoon. My name is Mieke Boon. I'm a pediatric pulmonologist and sleep specialist from the University Hospital in Leuven, and we will try to do a little bit pro and con for the diagnostics of sleep disordered breathing in patients with achondroplasia, and I will try to focus on clinical indications, so diagnosis of sleep disordered breathing in this patient group based on symptoms. Brigitte already told you. I'll try to...
You should have control. You may need to click once or twice. There we go.
Okay, yeah, thank you. So just as a small rehearsal, we already heard from Brigitte that patients with achondroplasia are at risk for sleep disordered breathing, and that sleep disordered breathing can present in three different kinds of problems. So the typical obstructive sleep disordered breathing, because of their anatomic abnormalities of the midface, because of a problem of dental malocclusion, which we see very often in this patient group, and additional obesity can increase the problem. They also are at risk for hyperventilation because of restrictive lung disease, because of their small thoracic cave, a risk of scoliosis and muscle hypotonia. And last but not least, the problem of the central sleep apnea caused by abnormalities of the foramen magnum and compression of the myelin, leading to central sleep apnea. So if we want to screen for symptoms of sleep disordered breathing, it's of course very important that we know what symptoms are caused by sleep disordered breathing. And I think you all know, but we will just do a rehearsal. Of course, snoring is one of the most frequent symptoms in children with obstructive sleep apnea syndrome. Children with OSAS might sweat during the night. They might have a very abnormal sleep position with hyperextension of the neck and the head, just to be able to breathe and to open the airways. And as a consequence of sleep disordered breathing during the night, these children may be very tired during the day, might complain from headaches, nausea in the morning. They might wet their bed during the night because of disrupted sleep, because of obstructive sleep events. And as secondary effects caused by obstructive sleep apnea, we know that there's a risk of hypertension, hyperactivity and attention problems, and learning disabilities or learning problems following this very bad sleep quality because of disrupted sleep due to the obstructive events. So in general, if we look at the indications for polysomnography based on the guidelines from the ERS task force, it's always said that the diagnosis of sleep disordered breathing or obstructive sleep apnea should be made on the combination of sleep disordered breathing symptoms in combination with abnormalities on polysomnography. And there's a bit of difference between the definitions of these OSAS, but it is either combination of symptoms with AHI above 2 or above 1 if these are all obstructive events. Also, the AASM indicates that polysomnographies should be performed in children with symptoms suggestive of obstructive sleep apnea syndrome. This is, of course, all in children without underlying comorbidities, and especially in children with achondroplasia, they suggest to screen if symptoms are present. So if you just look at the guidelines for performing polysomnography, we see that mainly clinical indications are put forward for performing polysomnography studies. Brigitte has already suggested or told us that there is a bad correlation between history of snoring and history of symptoms during the night and the abnormalities found on polysomnography. And we know that this is especially true in children with underlying pathologies, like, for example, the children with achondroplasia. But of course, we can try to screen for symptoms on a more systematic way. And there's a lot of questionnaires developed to screen children for sleep disordered breathing. For example, the pediatric sleep questionnaire. And this is a questionnaire that's used very frequently to screen for sleep disordered breathing. It's a questionnaire composed of 22 different questions, and in a healthy population, so healthy children without underlying diseases, We know that the sensitivity is around 85% for the diagnosis of mild obstructive sleep apnea with an index above 5. Specificity is also quite good, around 85%, with a cutoff of 0.33. We know, of course, that the accuracy of the questionnaire is dependent on the used cutoff, and this is only true in healthy children. Just have a quick look at the questions that are used in this PSQ. So there's actually 3 categories of questions. A lot of questions about the snoring and the breathing of the child. A lot of questions about secondary symptoms like feeling tired during the day, abnormalities during school activities, and a lot of questions on behavioral issues. And especially if we look at the questions for nighttime snoring and breathing, we know that the diagnostic accuracy of these specific questions are a little bit better than the whole questionnaire with all questions. If we now look at the diagnostic accuracy of this PSQ in children with underlying abnormalities, like, for example, a group of genetic metabolic syndrome, which includes achondroplasia, but also Down syndrome and other syndromic pathologies, we can see that sensitivity and specificity really decrease to like a sensitivity of 63 and a specificity of 32%, which leads to a positive and negative predictive value around 50%. Another study as well showed that sensitivity and specificity were only around 50%. And if you know something about accuracy of diagnostic tests, you know that this is really not better than just flipping a coin. So do we have to screen children with achondroplasia for symptoms of nighttime breathing abnormalities? Well, I think everything depends on the cutoff you use for example, the PSQ, because if you increase the cutoff you use to say that something is abnormal, then the sensitivity and the specificity of the abnormality will increase. And this was also shown by a good correlation between abnormalities on the PSQ and the index of the apnea-hypopnea index on polysomnography. It also has been shown that if you increase the value of the PSQ or the cutoff value for the PSQ, that the diagnostic accuracy can be improved for moderate to severe OSAS, and that's actually the most important group to pick up. So patients with an apnea-hypopnea index above 10. Maybe we can have a higher success rate of treatment with, for example, nasal CPAP if we just screen children based on symptoms, because the goal of treating patients with CPAP is to improve quality of life, to reduce symptoms. And of course, if patients don't experience symptoms, then there's maybe nothing left to gain. A higher apnea-hypopnea index might be more predictive of treatment adherence. And at least in my experience, patients with severe OSAS are more compliant and are more easy to adhere to CPAP treatment. And there might be a window of opportunity because the younger age is more successful to start CPAP than older age. Of course, it's not always representative of the sleep at home, because there's rather an overall evolution than one night. And of course, this is what the polysomnography evaluates. It's only a one-night evaluation, where if you ask for symptoms, you have symptoms from more than one night. An advantage of using symptoms to screen is that there won't be an overuse of polysomnography. It's a quite invasive exam for young children. It's costly. And of course, in these special patient groups, a lot of polysomnographies are already performed and needed in this population at risk. And maybe we don't have to screen in a systematic way, but just wait until the symptoms are clear enough to perform polysomnographies. For example, in patients with clearly hypertrophic tonsils, symptoms of OSAS, isn't it affordable to just perform a tonsillectomy without doing polysomnography beforehand, but just do polysomnography afterwards to screen for residual OSAS after tonsillectomy? What might be disadvantages of just using symptoms to screen for sleep disordered breathing? Well, of course, parents don't sleep always together with their children. So maybe in some cases, nighttime symptoms are not picked up or might be underestimated. It's of course very hard to ask the children themselves for symptoms. The sensitivity of the questionnaires might be suboptimal, and especially for the central sleep apneas, the symptoms can be very vague. Mostly there's no snoring, there's not a lot of very clear or specific symptoms, and it's more difficult to catch up the central sleep abnormalities. There is a link to the neurologic problems, of course, and if this is missed, there is also a risk of sudden death if it's not recognized. Hypoventilation as well induces vague symptoms and therefore can be missed if just using symptoms to screen. So because the time is up, I just want to finish saying that if we look at the guidelines for follow-up of children with achondroplasia, it's just a screening polysomnography between birth and 1 month of age, but then afterwards, just as indicated, and so in case of suggestive symptoms. Any questions?
Thank you very much, Mieke. Maybe we can have a discussion at the end after the presentation of Nuria.
Perfect.
So Nuria, it's up to you.
And Nuria, you have control of the slides now as well. Can you hear us, Nuria?
Nuria, your microphone is not on. Can you put your microphone on?
Now it's on.
Okay.
So
We
sorry.
have you now.
So sorry. I thought that it was automatic that you did that. Sorry. So I was saying my name is Nuria. I'm from the pediatric department in University Hospital in Coimbra, and I'm a part of the multidisciplinary team that follows children with achondroplasia from different parts of Portugal. So I will talk you about screening. Next slide, please. Screening for sleep disordered breathing. Why should we screen? So one of the main reasons for screening, it was already said, it is one of the objectives of European Achondroplasia Forum, that we have to enable anticipation of the problems, not just wait for them to get all the consequences, but to anticipate so that we can do early diagnosis and early treatment. And we are talking about a high prevalent problem that is as high as 56% in infants and children and remains high in adults. And for these children, these achondroplasic children, mainly in young infants, symptoms may be discrete or even absent. And even if they are present, parents may unnotice or underestimate them. And it's not unusual that we ask for snoring and parents says, no, I don't sleep with him, or usually I don't find that snoring, or even in Portugal and probably in other parts of the world, snoring is considered normal because dad or mother also snores. So it's important to screen, and in what age should we do it? Next slide, please. At what age? Next slide. So one of the main goals is to find obstructive sleep apnea and central apnea before the age of 2 years. In this time, obstructive sleep apnea is mainly due to craniofacial abnormalities, air muscular hypotonia, and probably some malacia and some hypoventilation. But also we have to look at central apnea, as already has been said, and this is related also to an increase of mortality with the sudden infant deaths. So the first European consensus that was published in 2022 says that it's important to close monitoring these children in the first 2 years, and the respiratory assessment should include sleep studies and be managed by experienced specialists. So next slide. In this period of time, the Academy of Pediatric, American Academy of Pediatrics says that we should do it between birth and 1 month, but also between 1 month and 1 year, or at the time of diagnosis during this period, because sometimes children come to our evaluation later. So during this period of time, even without symptoms, we should perform an evaluation for a screening for sleep disorder breathing. That's also the same idea that is in the international consensus for 2022 that says that upper airway obstruction are common in children and should be a PSG or sleep study should be performed in the first years of age, or at the first signs of sleep disorder breathing, wherever comes earliest. So even without the presence of symptoms in this period of age, we should screen for sleep disorder breathing, not only obstructive sleep disorder breathing, but also central apnea and also hypoventilation. In Portugal, next slide, please. Next slide. We perform a case series that was published in the Portuguese Journal of Pediatrics, and we in 10 patients under 2 years of age, we perform PSG in all the children, even without snoring. And we found that 4 of the 10 patients had obstructive sleep apnea, mild to severe, but on these 4 patients, 2 needed CPAP or BPAP. So we are talking about a huge percentage of children with obstructive sleep apnea syndrome, no central apnea syndrome, but a huge percentage that, and 2 of them needed a therapeutic approach. Next slide, please. I also agree that we shouldn't perform PSG if the child has all the clinic and has a tonsil and adrenal hypertrophy, but after adenotonsillectomy, we should perform a study and screen for sleep disorder breathing. The percentage of residual OSA is different between studies, but a more recent study found that that was only present in 18% of the patients. And that's not difficult to understand, because here we have a multifactorial sleep disorder breathing, and tonsil and adenoids are just a part. So it's because of this probably that the international consensus also says that postoperative polysonography should be performed between 2 to 4 months after adenotonsillectomy to show the improvement or resolution. Next slide, please. One of the child that was part of that case series that I showed you before is this one that I bring. When she was 4 months, the parents report just a discrete noisy nasal breathing, and the PSG showed a severe obstructive sleep apnea. Then with the growth, she started to snore when she didn't have the CPAP, and at 4 years of age, she needed to perform an adenotonsillectomy and laryngotomy for upper airway infections and ear refusion. After the procedure, parents didn't report snoring, so they stopped NIV. The PSG that we performed later found a severe obstructive sleep apnea, so CPAP has to be restored. So this is one example of the need of performing screening after a surgical procedure. Next slide, please. The other surgical procedure that can be used in these children is maxillofacial surgery. We know that these children have a lot of craniofacial abnormalities, and in this recent study, they show that probably this will be worse with age. So these children usually can be referred to maxillofacial surgery in adolescence. And there are a few studies that show that it's possible to have residual obstructive sleep apnea syndrome. This was one of the studies from 2017 that showed that with Lefort 3, it was possible to have no improvement of obstructive sleep apnea. The index was similar. So probably we will need to check up for resolution after the surgery, maxillofacial surgery. Next slide, please. You can click again, please. Again. Okay. So the other thing that is important in adolescents is obesity. In a study for 2021 in adults, they found that one of the most important variables that predict for OSA was obesity. And here we have a protocol that establishes that if the children has severe obesity or a sudden increase of weight, we should perform a PSG even without symptoms. And I think that the same applies to achondroplasia. This is one example of a child that is now 10 years, and she didn't snore, she didn't have any symptoms, and her BMI was upper than the 95 percentile, and we found a mild obstructive sleep apnea. You can ask why is this important? She doesn't have any symptoms, but I think that is important because of the cardiovascular risk and the probability that this can increase with age, increasing the cardiovascular risk that is already increased by obesity. So we have to anticipate and be more careful with the control of weight in this child or adolescents. Next slide, please. So how should we do it? I think that it's important and wherever possible to do polysonography because of the lack of understanding in the other sleep studies. In cardiorespiratory polygraphy, we don't find TCCO2, and we already saw how this is important. The events and the total record time can be underestimate the index, and in nocturnal oximetry we cannot find the hypopneas related to arousals, only the hypopneas related to desaturation. This is one example with the normal nocturnal oximetry. Please, next slide. And if you can see, this child had a lot of hypopneas raras and a lot of airflow limitation. So this child had a severe obstructive sleep apnea with a normal nocturnal oximetry. Next slide. Of course, that we have problems with the technical and human resources. So it's recommended that if we have to do alternative methods, but with those alternative methods, we have to be careful about the age of the child, the importance of performing monitoring of TCCO2, and of course, the limitations of the family that sometimes cannot perform home PSG. Next slide. So in resume, it is important to enable anticipation, identification and treatment of sleep disorder breathing. This is a high prevalent complication and symptoms may be discrete, absent or underestimate. I think that we should screen for sleep disorder breathing in every infant or child before the age of 2 years. At any moment at the diagnosis, after adenotonsillectomy, after craniofacial surgery or maxillofacial surgery, and in the presence of a severe obesity or sudden weight increase. The pros will be, of course, the early recognition and treatment of sleep disorder breathing, avoiding its consequences. And of course, the cons, the only cons that I really find is that we all have limited human and technical resources. Thank you. Next slide. Thank you.
Noya, thank you very much. We see now together the guiding principles. Next slide, please. So here the response of another question of the survey. Does your center have a protocol for routine screening for sleep disorder breathing? So 11 centers responded yes, 3 no, and 1 don't know. Next slide, please. At what age do you routinely screen for sleep disordered breathing? So you see the dark is the center has a screening protocol. So essentially for children within the first years of life, with a number of centers significantly decreasing in older children. And you see that also the percentage of centers who don't have a screening protocol are mainly centers who care of older children, adolescents, and adults. Next slide, please. So here it's a bit complicated table, but it shows you the frequency of routine screening according to the different age groups with a number of comments. Next slide, please. Next slide, please.
So this one is the next one. This is when people are planning to cease routine screening.
Ah, okay.
On this column here.
So outside of routine screening, what clinical indicators would prompt a sleep study at different ages? So this is also a complex figure showing you for the different age group, the different clinical symptoms. And you can see that the gray, which is more the snoring, is mainly the most important symptom, followed by excessive daytime sleepiness. But you see the large heterogeneity of the responses. Next slide, please. So guiding principle 3, screening for sleep disorder should be undertaken routinely throughout the life course with particular focus on the early years of life when onset is more common. So please, if anybody of the audience has some comments or questions, please go on. So maybe we can just vote on the content and the wording. So first, do you agree with the guiding principle? And second, rate your level of agreement. Please vote.
Okay, so about half the participants already. We'll go another 10 seconds or so, please, Alex. Okay, 1 or 2 more responses coming in. Great. Thanks, Alex.
So again, we have 100% agreement with the guiding principle. And also, I think a quite 70% rate of agreement with the wording. So thank you very much. We will discuss this further on. We will have a 15 minutes break. So we will restart again at 3:45.
Sorry, Brigitte, may I jump in there? There is a second guiding principle for us to review here.
Sorry, I thought there was only one. Sorry.
No, that's okay, no problem.
So if sleep disorder breathing is suspected, referral to a specialist should be made as soon as possible. sleep study results should be assessed by a specialist with knowledge of the respiratory characteristics of achondroplasia specific to the age of the patients. So before voting, if somebody of the audience has any comments.
I'm Lino Nobili. Brigitte may well, this is a tricky question, I think, because, you know, sometimes you are a specialist in achondroplasia, but you don't have the sleep specialist close to you. So I think if you are a good sleep specialist, then you can score the sleep trace and also give really an interpretation of the respiratory activity. And then you share the results with the specialist on achondroplasia. Could be.
I think it's a very good comment, and I think it's relevant. Maybe we should change it for a multidisciplinary team.
Yeah,
where
I think so.
The sleep specialist can discuss his results with somebody who has knowledge of the respiratory characteristics of children and adults with achondroplasia.
Yeah.
So
Okay, let
maybe
me just change that wording. Bear with me one moment.
Maybe we can just change for a multidisciplinary team. What do you think, Lino? Your camera, your microphone is off.
No, I would say that I agree, because, you know, you create a multidisciplinary team where you can have the specialists, but then could be that not everybody can really be a great scorer or sleep, although it's a special in achondroplasia. Otherwise, if you have a multidisciplinary team, if you do all alone, you must be all included. So especially pediatrician, achondroplasia, and then also sleep patient. But I think it's sufficient that if you work in a multidisciplinary team and you can share your results, this could be sufficient.
So does the wording now suit you? Do you agree?
Could be assessed by a special with knowledge of.
May I just quickly comment on this? It's also depending on the question for the polysomnographist. If the achondroplasia specialist can really ask for specific things on the polysomnography, everybody who knows polysomnography can answer this question without having experience in achondroplasia.
Yeah, it's what I was saying. Yes. Yeah. I agree.
So maybe we should say referral should be made and maybe put within a multidisciplinary team at the end of the sentence. I would have put it at the end.
Okay.
Referral
So we have
should
referred
be made. Yeah,
as soon as possible within a multidisciplinary team, or referral to a specialist within a multidisciplinary team.
Specific to the age of the patient, comma, within a multidisciplinary team.
So is this bit here correct? Referral to a specialist should be made as soon as possible. Sleep study results should be assessed by a specialist with knowledge of the respiratory characteristics of achondroplasia specific to the age of the patient. I wonder if that actually sits better in there. How does that look now?
Sorry, for me it's not clear, because you are saying if you suspect a sleep disorder briefing, and then you refer the patient to a specialist. Here you mean the sleep specialist, or what? Because sleep study results should be assessed by a specialist with knowledge of the respiratory characteristics. So a sleep specialist, because you can be a specialist in the sleep respiratory briefing, but not a sleep specialist. You know what I mean?
Now, can you put the sentence again? I have another proposal. If sleep disorder breathing is suspected, a sleep study should be performed and the results should be assessed. A sleep study should be performed with scoring made by a specialist, by a pediatric or adult sleep specialist.
I would say with the sleep specialist.
by a sleep specialist.
Yeah, and possibly discussed with the multidisciplinary team.
And the scoring made by a sleep specialist, but the interpretation and the therapeutic management should be performed within a multidisciplinary team. Interpretation and therapeutic management should be performed within a multidisciplinary team. Is that better for you?
I think so. I think so.
What do you think?
I think it's much better than now, no? So there is this especially as soon as possible.
Interpretation
I think,
should be performed within.
Yeah.
Within an achondroplasia MDT.
Yeah.
An achondroplasia MDT.
Yeah, an achondroplasia multidisciplinary team.
Okay.
Do you agree better? Yeah?
Yeah, I can see Nura nodding. Do we have any hands raised, Kate?
So I
Any
see
further
there
comments?
are 2 people.
No, can't see any other comments at the
No hands
moment.
raised. Okay,
No.
so if sleep disorder breathing is suspected, a sleep study should be performed with scoring made by a sleep specialist as soon as possible. Interpretation and therapeutic management should be performed within an achondroplasia MDT. Okay, Brigitte, are you happy there?
Yeah.
Yes, yes. Lino, do you agree? And Joseph and Mieke? Yeah? Okay, so
lots of nodding.
We vote on this, on the principle, and then the level of agreement.
Thank you, Alex. Okay, so approximately 50% of participants. So if there's anyone else left to vote, please do so. And Alex will go 5 more seconds, please. No, thank you.
Okay, so 100% agreement, and I think a better level of agreement for the wording. Okay, perfect. Thank you very much. Kate, should we shorten the break to 10 minutes or keep the 15 minutes break and start at 4:05?
I think we can take 10 if you're happy with that, Brigitte, and start back again on time.
Yeah, okay,
we'll start back
perfect.
in 10 minutes.
Yeah, okay, perfect.
Okay, thank you all.
Shall we start again?
Yeah, I think that's a good idea. I'll pass you control, Brigitte. If you click once or twice, you should be able to take control of the screen.
No, it does not work.
It's not working? Okay.
No. So we will now see in the second part the therapeutic options. Next slide. Next slide. So we will see for the different types of sleep disordered breathing, the therapeutic options. Next slide. So this therapeutic option require a multidisciplinary team, as we spoke about before. Next slide. So first, concerning obstructive sleep apnea, when the sleep study has diagnosed an obstructive sleep apnea, the first step is ENT surgery, followed in a stepwise progression by orthodontics or maxillofacial surgery, neurosurgery, and a tracheostomy, really at the last solution when every other treatment has failed. And CPAP, or continuous positive airway pressure, can be proposed at every step if those surgical treatments are not indicated, not possible, or fail or are insufficient. Next slide. So ENT surgery is the first line treatment. The aim is to remove all the obstacles that decrease the upper airway diameter The type of surgery depends on the age, and what is very important and is highly recommended is drug-induced sleep endoscopy, which is able to identify the different level of obstruction. Indeed, children can have hypertrophy of the turbinates, the adenoids, the tonsils, or lingual tonsillectomy. So a full checkup has to be made in order to have a surgery that is as effective as possible. So repeated surgery may be necessary. Also, these children are at risk of anesthetic problems. So it's necessary to have an anesthesiologist who has an expertise in achondroplasia, and all because of their underlying achondroplasia. It is not recommended to perform ambulatory surgery in those patients. Next slide. So you can see here that different types of ENT surgery can be combined: tonsils, adenoids, or associated or not with turbinectomy. Next slide. But we know that this ENT surgery is not always sufficient, as you can see here, where 2 children had persistent mild to severe obstructive sleep apnea after ENT surgery. Next slide. So this is the stepwise treatment approach published in the US task force that says that when ENT surgery is not sufficient, then in selected patients can be discussed orthodontic treatment, CPAP, or craniofacial surgery. Next slide. Indeed, rapid maxillary expansion can be proposed in selected patients. However, these results have not been published in the achondroplasia population. Here you see thus the results in children without an underlying disease that showed that normally those children have quite moderate obstructive sleep apnea, but with a significant improvement over the 1 year of treatment. Next slide. Another orthodontic treatment is mandibular advancements that can be proposed in children with obstructive sleep apnea related to malocclusion. There again, those children have generally mild obstructive sleep apnea, but with a significant improvement after 3 months. However, again, this treatment has not specifically been evaluated in children with achondroplasia. Next slide. What is interesting, that is the combination of those orthodontic treatment with ENT surgery. And you can see on the table at the bottom, when those treatments are combined, then the results are the best. Next slide, please. So the Cochrane collaboration showed that for oral appliance and functional orthopedic treatment, it can be helpful in the treatment of obstructive sleep apnea in children with craniofacial anomalies. Next slide. Concerning maxillofacial and neurosurgery, in case of very severe facial anatomy, they can benefit from a LeFort 1, which is surgery of the maxilla, or a LeFort 3, which concerns also the midface, and which is a more difficult surgery that can be proposed when there is also an hypoplasia or retrusion of the midface. Next slide. At least when all those treatments are insufficient, then continuous positive airway can be proposed, which is the delivery of a positive airway pressure during the inspiration and expiration, which opens the airways. The advantage of this non-invasive treatment is that it treats the multi-level obstruction of the airway and that it can be used ad libitum, and especially during sleep, daytime sleep, or in infants, or and mainly overnight sleep in older children. Next slide. So you can see here in a quite recent study the perfect correction of obstructive sleep apnea in a group of children with achondroplasia. And you see here 4 patients who were treated successfully with CPAP. Next slide. Here again, the results of a center in the United States that shows you the number of patients who had ENT surgery, but also 20 patients who had CPAP, BPAP for the treatment of obstructive sleep apnea. Next slide. In France, we have a national network of pediatric NIV, and you see here the red column, which represent children with congenital bone disease. So over 1,449 children treated with long-term NIV or CPAP in France on June the 1st, 2019. Next slide. You can see that there were 23 children with achondroplasia treated with CPAP for severe persistent obstructive sleep apnea. Next slide. Let's see now the therapeutic option for central sleep apnea. Central sleep apnea is related to the cervico-occipital compression of the brainstem. So surgical decompression is the first line treatment with a multidisciplinary decision based on the symptoms and the age of the patients, the MRI findings, and of course, the results of the sleep study with the central apnea hypopnea index, and also the level of oxygenation. Next slide. You can see here, in our experience, we had 2 children, one with a spontaneous resolution of central sleep apnea with age, and another patient who had also Down syndrome, who moved away, who moved abroad, and who was lost for a follow-up. Next slide. Again, here the results of the American Center. You can see that 19 children presented with sleep apnea, and that most of the patients grew out of their sleep apnea with age, and some others were treated with CPAP, BPAP, and 5 with oxygen. Next slide. Concerning alveolar hyperventilation, so again, no validated definition. The most commonly used definition is a transcutaneous CO2 above 50 millimeters of mercury during at least 2% of sleep time or more than 5 consecutive minutes. Next slide. Then again, you can see that alveolar hyperventilation may be associated also with severe obstructive sleep apnea. You see that the maximal PCO2 was the highest in the group with obstructive sleep apnea, which is the right column. Next slide. So in case of alveolar hyperventilation, if the patient has associated obstructive sleep apnea, the first recommendation is to treat obstructive sleep apnea first and propose CPAP if failure of other treatments. However, if there is no obstructive sleep apnea, then NIV is recommended to increase tidal volume and minute ventilation, as you can see here, because NIV is associated with an increase in tidal volume, and thus consequently normalization of the transcutaneous CO2. Next slide. So as a conclusion, the treatment of sleep disordered breathing should target the type of breathing anomaly. There is always a need of a multidisciplinary decision by experts in achondroplasia. There should always be a stepwise therapeutic management, taking in account the patient age, the type and severity of sleep disordered breathing, and also the patient's and parents' acceptance, involving preferentially a shared decision taking. Of course, treatment efficacy should be checked by a sleep study after each intervention. And for all those patients, there is clearly a need for a long-term, lifelong follow-up. Thank you very much.
Thank you, Brigitte. There is a couple of questions in the chat from Joseph. Asked, does high flow nasal cannula have any place here as a CPAP light?
Yeah. So high flow nasal cannula can be proposed as an alternative to patients who don't tolerate CPAP. The inconvenience is that we don't know exactly what level of airway pressure is delivered by a high flow nasal cannula, and also adherence. It's difficult to be assessed on an objective way, but it can be proposed, and we have published the efficacy of high flow nasal cannula in children with obstructive sleep apnea and underlying disorders. We sometimes use it at our center. Yes, it's an alternative when CPAP fails. I totally agree.
Great, thank you.
Okay, so it's my time.
It is, Alina. You do have control, so if you click the slides, you should be able to move them back and forth. There you go.
Yeah. So good afternoon, everybody. I'm Lino Nobili, a clinical neurophysiology and child neuropsychiatrist, also a specialist. I've been working with the adults and children, and now I'm here at the Children's Hospital, Gaslini Children's Hospital in Genoa. So now we are talking about adults. And we know we have also listened to the previous talk that, for example, obesity can be a characteristic of achondroplasia, and this is especially in adults. So high BMI, abdominal obesity is frequent in adults with achondroplasia. And if you look at this paper, indeed, it's underlined that there are not so many studies looking at sleep apneas in adults with achondroplasia. I will show you just a very recent one. So these are the recommendations that you have seen before. So these are recommendations for children. And you see here that is adenotonsillectomy is proposed as the first-line treatment for obstructive sleep apnea. And however, also additional airway surgery may be necessary. Indeed, as Brigitte was saying at the beginning, it's not sufficient in the very high percentage of subject adenotonsillectomy alone. And indeed, we are talking here about a kind of multi-level airway surgery for these patients. So now this is the paper that someone showed also before. This is in adults subjects, and you see the high prevalence of obstructive sleep apnea in this population. That is about 59%. Yes, it's 59% of subjects are affected by sleep apnea, and 16% are affected by a severe form of sleep apnea. If you look at the table, you can see that a high percentage of these patients have been submitted to surgical intervention of adenoidectomy or tonsillectomy. So this is not sufficient. It's not an intervention that can really avoid the evolution towards sleep apnea in adulthood. So sleep apnea seems to be very frequent also in adults. And so, which are go back, sorry. So this is, again, the recommendation, and the recommendation, for example, in children as a kind of first-line approach is CPAP treatment. And however, also in this recommendation, they are talking about other surgical approach or other approach like maxillary orthodontic expansion, so non-surgical protraction of the upper airway volume. However, if you look, this is a sentence from the paper: further investigation should be made into the natural history of achondroplasia in adults. So if we consider the guidelines in adults, sorry, okay. The CPAP is considered the gold standard treatment for OSA in adults because it can improve sleep-related symptoms and also the quality of life. And so this is really the first-line treatment for all OSA patients. So I think we should apply also this recommendation also for adults affected by achondroplasia. Try to go, okay. Sorry, I click and then, okay. Here you see the recommendation from the American Academy of Sleep Medicine. Again, you can see here that there is a strong agreement in recommending CPAP treatment, both automatic of, with the titration in the lab. However, there is a strong recommendation on using CPAP treatment. Okay. And you see the other, when the patient is not able to use CPAP or the compliance is very low, you can also propose other possible treatment for obstructive sleep apnea. You can see here oral appliances, surgical treatment, different kind of surgical treatment on nasal, palatal, tongue surgery or maxillomandibular surgery, even the hypoglossal nerve stimulation, or other approaches, behavioral approach, positional therapy, weight loss, and so on. However, if you look at the recommendation from the European Respiratory Society, these are the guidelines on non-CPAP therapies for obstructive sleep apnea in adults, you can see that for all the other possible approach that are surgical, mandibular advancement, or hypoglossal nerve stimulation, there is very, very low quality of evidence. So they can be effective in single subject. They can have also success in treatment, but we have not so many studies, so many evidence to recommend this treatment, I think, before CPAP. And also, if you look, for example, myofunctional therapy, maxillomandibular osteotomy, or the use of drugs, for example, there is a very low quality of evidence of the effectiveness of many of these treatment. And again, also positional therapy indeed can be extremely useful, but we have not so very big population study with the positional therapy, although in our clinical practice, especially in adults, this can work. It's not easy, however, to assess the compliance with the treatment. So I would say that although we don't have really data on adults with achondroplasia, I would consider CPAP as the first-line treatment for this patient. Here we are talking about simply obstructive sleep apnea. Is for sure, if you include also hypoventilation, we should include non-invasive ventilation. However, for example, for central sleep apnea in adults, there is still a great debate if we have to treat or not, also periodic briefing. So this is probably related more to the symptomatology of the patient. So if the patient has a sleep fragmentation or is sleepy during the day, then this means that probably central sleep apneas have a negative impact on sleep structure. However, going back to obstructive sleep apnea, I really would take this take-home points also good for achondroplasia. So CPAP as first-line treatment, and then we have other choices that we will see in the future if we will start also with some of these approaches, but we need to have some well-designed study in order to really conclude with a clear recommendation with respect to this other treatment, not CPAP treatment. So I think I have finished. Yes. Thank you very much.
Thank you very much. May I just make a remark before discussing?
Sure.
Yeah, you know, we are always quite reluctant to CPAP, even if it is a very efficient and well accepted treatment in children with achondroplasia, because of the deleterious effects of the nasal interface on the facial bones in achondroplasia. We know that these patients have mid-face hypoplasia and retrusion, and we are now demonstrating with RMI and imaging that the continuous use during the night of CPAP exaggerates the mid-face hypoplasia and retrusion. So this side effect in this specifically susceptible population is a real problem. And this exaggeration of the mid-facial deformity makes it more and more probable that those patients will need maxillofacial surgery or neurosurgery after puberty when their growth is completed. So we have to really see the balance of CPAP and other treatments. So those children really, I think, must be followed up by a maxillopediatric surgeon.
Yeah, this is for children, but for adults, if you have a sleep apnea in adults, imagine in the paper of the innovation paper, there were half of this diagnosis was the first diagnosis. Imagine that you have an adult with achondroplasia that arrive with a severe obstructive sleep apnea. I would start first with CPAP, because then the development of the bone is done. So I would start with that.
Yeah, and but Lino, excuse me, but still in healthy adults without bone disease, they have shown that the long-term use of CPAP can cause some facial deformity. So I think that we don't have we don't have enough experience and enough follow-up, but we must be very careful.
Yeah, sure. This is a matter of debate, but in my clinical practice, I would recommend first CPAP. I agree. Then you have to follow up, or even you can try nasal pillow, for example. You can try to use other approaches.
Exactly.
Yeah.
We have nasal pillows for children weighing more than 25-30 kilograms.
Yeah.
So if the children accept, and if we can find nasal cannula or nasal pillows which are adapted to the size of the nostrils, we should use nasal pillows or nasal cannula as a first-line interface.
I agree with you with this.
Okay.
Absolutely. I'm also a fan of nasal pillow. They can
Mieke,
really
do you have a comment?
Yeah, I just wanted to comment on what you said, Brigitte, because I totally agree with you with what you mentioned about the risk of increasing the pressure on the maxillary bones. But what would then be your advice, for example, in a child of 2 years old with a mild obstructive sleep apnea without a lot of symptoms? Do you agree just not to treat them and to follow up and see what happens? Because there's not a lot of other options, just as maxillofacial surgery.
I think that even moderate obstructive sleep apnea should be treated. So an infant, I would start CPAP. However, I would make ENT evaluation with these regularly every 6 months. So as soon as we observe a hypertrophy of the adenoids or
of
the
course.
turbinates, we propose surgery. And also we have written in our US task force that children with an underlying disorders who have obstructive sleep apnea, we must evaluate the need to continue CPAP every year. So those children can grow out of their obstructive sleep apnea. So we should make regularly sleep studies in spontaneous breathing to see if we can stop the CPAP. Shall we go on to the results of the survey? So here the first question, which therapeutic options are available for the treatment of sleep disorder breathing at different ages? So you see that the response varies according to the age group. And for young children, you see that there are nearly no orthodontic treatment, no maxillofacial surgery, but mainly neurosurgery, CPAP, and in case of failure of those treatments, tracheostomy, while for other older age group, all the different types of medical and surgical treatments are available. Next slide. So the first poll, in each grade age group, please rank therapeutic options in order of what you would try first to last. So I can't see all the numbers, but please rank therapeutic options in order of what you would do to try. So upper airway surgery.
If you can make this, sorry, Brigitte, if you can make this a full screen by pressing the square in the top right-hand corner, then you will be able to see all of the options, which will make it easier for voting.
Sorry, now I lost it completely. I don't have it anymore, sorry. I don't have the question anymore.
Okay, so the poll is...
I'm just going to end it and then start it again. And hopefully that should help. Okay, can you see that now, Brigitte?
Yes, but...
so yes, you can expand the size of the box. You might need to scroll down slightly on the voting box and then pull that to the right, okay, so it expands it slightly. And there are 6 questions in there as they look at each of the different age groups.
So we have upper airway surgery, orthodontic treatment, maxillofacial surgery, neurosurgery, CPAP, tracheostomy. Best option, and we see 1 to 6, starting with the best option, which is quoted 1, and least favorable option, which is quoted 6.
And sorry, may I ask you, best option for what? For we are talking about a diagnosis of obstructive central sleep apnea. We're talking about what?
No, it's you are right. No, I think that this is for... It depends on the type of sleep disordered breathing. I think it is obstructive sleep apnea, because central apnea is completely different.
Yeah, because I see neurosurgery. So
yeah, no, I think that maybe this will take too much time and also is dependent on the type of sleep disordered breathing.
That's absolutely fine. If we think we won't get anything valuable from it, we can always follow up with a survey after the meeting.
Yeah.
Okay. Thank you. Okay, let's move on to the guiding principle then.
Stepwise therapeutic management should be individualized to the type and severity of sleep disordered breathing and the age of the patient. do you want to make a comment before the voting?
Can't see any hands up.
So maybe we can vote? So the agreement, yes or no, and the level of agreement, strongly agree 10, don't agree at all, 0. No, 1.
Okay, so we're about 50% of participants have voted so far. So let's go another 15 seconds, please, Alex. And if you've not voted yet and you'd like to, please go ahead. Okay, let's close it there then, please.
Okay, so agreement 100% and the rate of level of agreement also excellent. I see 91% strongly agree or quote 9. So I think that is quite good. Thank you very much. So Mika and Lino, we listen to you.
Okay, Mika, and I've given you control if you'd like to take that over.
Okay, I just had to unmute. So I prepared an interactive case, a pediatric case, and I think we just want to rehearse all principles we've seen today and we've heard about today in a practical clinical case. So I want to present you John. John is a patient with a diagnosis of achondroplasia. He has a typical mutation in the FGFR3 gene. And actually, he was not followed in a multidisciplinary team until the age of 4. So it's a historic case. So he's now 20 years old. And so he was not followed in a multidisciplinary team until the age of 5 years. So at the age of 2, he was seen by a local ENT doctor because of snoring, recurrent rhinitis, and nasal secretions. He had small tonsils on clinical examination on that moment, and an adenectomy and ventilation drains were put during an anesthesia. At the age of 3 years, a redo adenectomy was performed because of persistent snoring and because of persistent problems with infections of the ears. New ventilation drains were put. And then he was referred for the first time at the age of 5 years old to our pediatric pulmonology department because of persistent snoring, because of witnessed apneas by the parents, headaches, vomiting with secretions. And at that moment, we saw tonsils grade 2. So my tonsil hypertrophy at that moment, causing snoring and causing probably obstructive sleep apnea. So my first question is, what would be the next step in diagnosis and management of this child? Oops, sorry, I already went too fast. So the options I put forward were a redo adenectomy, a tonsillectomy, an adenotonsillectomy, polysomnography, or an MRI of the brain. So try to be fast in voting because I have prepared a lot of questions and I only have 20 minutes.
Yeah, Alex, I think you can close it there.
Sorry? Everybody can vote now?
Yeah, the vote should be closed.
Aha, okay. But I can't see the results or the answers of the voting.
So we had 12 of 12 said polysomnography.
Okay, perfect. So I think indeed we've seen, and now I want to go to the next slide. I can't, okay. So indeed we've heard quite often today that we have to perform polysomnographies in these children and that we have to really objectify the abnormalities on sleep studies. So we performed a polysomnography in this child. He had a very severe obstructive sleep apnea with an index of 31. It was mainly obstructive events, as can be seen here. These are actually the blues are the apneas, the green ones are the obstructive hypopneas, with events mainly occurring during REM sleep, desaturations because of the obstructions, and a mean saturation during the night of 94%. So a severe obstructive sleep apnea was diagnosed. And so what is now the next step for the treatment of this child? And so again, I put forward 5 options: adenectomy, tonsillectomy, adenotonsillectomy, start nasal CPAP, or perform an MRI of the brain. You can vote now.
Okay, and let's pause it there, please.
I can't see the answers, but I can't see the numbers of the votes. I just can see.
So we have 1 of 15 said redo adenectomy. 5 said adenotonsillectomy. 8 said start NCP, and 1 perform MRI.
Okay. What the correct answer that I gave is adenotonsillectomy, and hope you all agree on this, because it was only grade 2 tonsils, but of course in patients with a considerable increase of tonsil hypertrophy, it's important to remove the tonsils, because these are very important and a very important part of the obstruction, even in children with underlying disorders. So the tonsillectomy was performed. During anesthesiology, the ENT doctor checked for adenoids again and removed a small part of adenoids hypertrophy again. But after surgery, the snoring persisted. He didn't have headaches. There was no vomiting anymore. He had a good sleep quality. But as indicated by the guidelines, a new polysomnography was performed, and he still had obstructive events with an index of 15 per hour, but with less desaturations compared to the previous polysomnography. I maybe want to interrupt because I see some questions.
Yeah, I have a comment. Søren Berg. Do you hear me?
Yes.
Yeah. So you can get a good indication of your adenotonsillectomy in this child by looking at the signals in the respiratory parameters, because you see that he has quite a few apneas, which in children are very often, if they have tonsillar hypertrophy, it's very often significant with apneas, whereas hypopneas very often are significant for example, an adenoid. So in this case, I would definitely recommend adenotonsillectomy when you see the distribution of the respiratory event.
I have to go back because it was in the previous one. Not sure whether I can. No, I can't go back, apparently.
No, but take my word for it.
Yeah.
There was a mixture of
I wanted to
different
show, but yeah, I think you're right. Yeah.
So you often get a very good indication by looking at type of obstruction that they have.
Brigitte, do you want to comment on this? Or
yes, I think
anything else I said?
Pardon?
Yeah, I think that drug-induced endoscopy should be performed before another ENT surgery to look at all the potential airway obstruction. So
yeah, I'm
I
sure.
I would propose these before any ENT surgery.
You might not be right. It's a matter of debate, but I just want to highlight the fact that we do find indications of what to do in the ventilatory signals, which is a thing that people doesn't look for very much.
It was indeed also suggested by Dr. Anne Boudewijns to perform a DISE before a new ENT surgery. I think that's correct, but anyhow, the tonsils might be very important in this case, and to try to make some space in the upper airway to reduce the obstructions.
Yes, but she published a lot of this technique in children with craniofacial abnormalities, and also the European and the French scientific society agree on the necessity to perform a DISE before any surgery in those patients.
Yeah, well, as I already mentioned, this is a patient who is 20 years old now. So in that time, we didn't do DISE, but I agree that it should be done and that we should try to evaluate in a better way. But this is the way it went. So I just want to present the case as it is.
Okay, perfect. Thank you.
Okay, so the control polysomnography after the tonsillectomy showed improvement of the obstructive sleep apnea, but it was not completely resolved. And as we can see, the index is still 15 per hour, but with much more stable saturations at that time and less symptoms at that moment. So my question is, I want to go forward. What would be the next step, of course, because we see that there is residual obstructive sleep apnea, which is still severe with little symptoms. So what would be the next step? First option, watchful waiting, as there is no subjective symptoms, start nasal CPAP, hypocaloric diet, or perform an MRI of the brain to exclude central problems. I think the poll was ended, but I can't see the result.
It has. So we have 1 said watchful waiting, we have 6 of 8 said start nasal CPAP, and we have 1 of 8 said perform MRI of the brain.
Okay. So I think at this moment, we should try to start nasal CPAP because there's residual obstructive sleep apnea with an index of 15. There is a comment in the chat. Let me see. Does nasal inhalation steroids have any place in children with hypertrophic lymphatic tissue? I think that's a difficult question to answer because there's, as far as I know, no specific studies in children with achondroplasia. But of course, if there's hypertrophic adenoids, it's always worth to try to start nasal steroids, but they don't have a big effect in most of the cases where adenoids are hypertrophic.
There is another comment in there as well, Mickey.
Yeah, indeed, as there was already a surgery for 3 times, probably they won't have a big effect anymore. So we started nasal CPAP because I think that's the next step to take. We started CPAP with a pressure of 6 centimeters of water. Another polysomnography was performed just to check whether obstructive sleep apnea was resolved with the use of the CPAP at that pressure. We saw a decrease of the index to 3.5. Mean saturations were 96%, and there were only few residual obstructive events. So actually, we were quite happy with this at that moment. I see a question.
Yeah, it's me again, Søren. The adherence to the CPAP was good, I suppose?
Yes, at that moment it was, yeah.
Okay, because what I miss in this discussion, and I missed hitherto, is that we never discussed the sleep quality in these patients. And I can see at your newest EEG that he still has a lot of arousals. Is that correct?
That's indeed correct. There's quite a lot of arousals, but of course, this is a sleep study in the sleep lab, and it's always difficult to compare this to sleep quality at home. And if we just asked the patient and the parents, he had a good sleep quality at home with the nasal CPAP at that moment.
And he has.
And indeed, you are completely right that sleep quality is not always better with CPAP compared to without CPAP, but then we have to look and find solutions for that and try to see where we can adapt or where we can change anything.
Yes, because I mean, if he had an absence of symptoms, and as I can see, normal sleep cyclicity, And I can't see how much deep sleep he has here, but it seems as if it's not too reduced.
Yeah, the percentages are not indicated. It's probably around 10 to 12% if I estimate it correctly.
Not
It's
more
not
than
that much.
Okay.
No,
Yeah.
but as I said, it's a sleep study in the sleep lab, which is of course not always very reliable to what it is at home.
My message is that I often look at the sleep quality and their sleep before I start CPAP, because the risk of CPAP treatment in these patients might be that you disturb their sleep more than you help it.
Absolutely.
That's more or less what I wanted to say.
Yes, absolutely. But
There's a
subjectively,
comment-
there was an improvement in sleep quality in this patient. Absolutely. After start of CPAP treatment.
Okay.
There is a comment in the comments box from Brigitte about the efficacy in mild residual OSA, just to offer a comment.
I can't see the comments anymore. I don't know what I
Local
did.
steroids have demonstrated their efficacy in mild residual obstructive sleep apnea after ENT surgery in healthy children. But in this 5-year-old child with achondroplasia and severe obstructive sleep apnea, inhaled steroids will be insufficient.
Any other questions at this moment? Otherwise, we continue. So the new sleep study with CPAP is quite okay. He's sent home, he's using the CPAP. We see him back 1 year later at the age of 7. And again, he has complaints about headaches, fatigue, a bad sleep quality. Sleeping is not noticed because he doesn't sleep with his parents, and so the parents don't know whether he snores or not. And so again, there is a problem with sleep quality. And the question is, what should we do next? So possible answers: check CPAP compliance, increase the CPAP pressure, perform new polysomnography, or perform an MRI of the brain. And now you can all vote.
Okay, so we'll give it another 5 seconds. And let's close it there, please.
Okay.
So we have 25% saying check CPAP compliance, 25% saying increase CPAP pressure, 50% saying perform new polysomnography, and 8% saying perform MRI of the brain.
Okay, that's great. So I think indeed we always have to check for CPAP compliance. We always have to check for problems with the CPAP, for problems with the masks, for problems of leaks. So that's of course the first step. But we checked, is compliance is good. There's no problems with the mask. There's no problems with leaks or whatever other technical problem. So then I think we should perform an MRI of the brain, because he might have some central complaints and he might have central issues. We didn't do a new polysomnography yet, but we started with the imaging of the brain. And as you can see, he has a stenosis of the foramen magnum with a mild hydrocephalus. And so potentially this is the explanation for his complaints. So now, what would we do? Increase the CPAP pressure, perform a new polysomnography, switch to bilevel ventilation, or perform neurosurgery with decompression of the fossa posterior. I think this is an easy one.
Okay, so let's close it there, please. And we have 9% saying perform new polysomnography and 91% saying perform fossa posterior decompression surgery.
Okay, there is a little bit of discussion, and because we really wanted to be sure that these problems were the consequence of the central problems, and because the neurosurgeons were not completely convinced of the central problems being the cause of the sleep disturbance, we performed a polysomnography at first, just to objectify and to see what the evolution of the sleep problems were during the night. So this was a sleep study performed with CPAP, so CPAP at a pressure of 6, as it was always been. And what we see is an increase in central apneas. So these are the blue ones with a total index of 25 per hour, a completely disturbed sleep architecture, and frequent desaturations. And of course, this is not completely well captured, but here, the places where you can see it, there are decreases in saturation at the moments of central apneas. So actually, and as you can see in the bottom, there's no big problem of leaks, which we also checked during this polysomnography. So actually, the polysomnography shows an increase of central apneas, potentially because of the central nervous issues, and the boy was sent for neurosurgery. And so I will make a jump into the time. He was good for a few years. He continued to use the CPAP, and actually he still needed the CPAP because without CPAP he was snoring again. He was tired again during the day. The pressure was increased to 10 because he gained a little bit of weight and because he really snored with a pressure of 6. And when he's 15 years old, we see him back because of morning headaches, because of nausea, because of fatigue. He increased weight and he really was overweight at that moment. And he had a problem of progressive kyphoscoliosis. And so we did a new polysomnography where you can really see that he had a very bad sleep quality, a very long sleep latency. He didn't have a lot of obstructive events at that moment under the CPAP with a pressure of 10. There was quite some leak, but not really, really impressive. And when we look at his carbon dioxide levels, these were normal when he was awake, but as soon as he falls asleep, he has an increase of carbon dioxide levels to a mean of 52 and a maximum of 67 millimeters of mercury during the night. So actually, this makes us make the diagnosis of nighttime hyperventilation on top of the obstructive sleep apnea, which is treated with the CPAP.
So Miki, there's two questions, or there's two comments in the meeting chat. So one from Brigitte, to say she would have done a sleep study without CPAP to document CSA during spontaneous breathing, because a too high CPAP level may induce CSA.
Yeah, that's indeed true. We didn't do that at that moment, but it was clear that without CPAP, he was really snoring. And if we reduced the pressure, then he was snoring as well. So that's the reason why it was performed with CPAP.
Okay, and the second comment from Geert is, is foramen magnum stenosis only causing central apneas, or can it also result in obstructive apneas?
I think that's a very relevant comment, and there's some literature about it, that the central problem, so the foramen magnum stenosis, may also result in obstructive sleep apneas. It's typically linked to central apneas, but in some cases it's also linked to obstructive sleep apneas. And I have a few examples of patients with other underlying diseases, for example, with Chiari malformations, where the polysomnography mainly showed obstructive sleep apnea. But if the Chiari malformation was treated by neurosurgery, this obstructive sleep apnea was completely resolved. And then it might be linked to abnormal movement of the vocal cords, which can also cause obstructive sleep apnea.
There's another comment from Joseph.
My point was that brainstem pressure can induce obstructive apnea by desynchronizing respiratory pattern. Well, indeed, that's true. So it might be a mixed pattern, both central sleep apnea and obstructive sleep apnea, because of central neurological abnormalities.
Okay, and Brigitte has replied as well to say this is related to involvement of the lower cranial nerves.
Yeah, I think we only have 15 minutes left. I don't know if how many time Lino.
This was almost the end. So I think I already said what we would do, and this is just an overall slide to conclude that the problem of sleep disordered breathing in achondroplasia is very complex.
So Mieke, thank you very much, because it's an extremely interesting case, which underlines the multiple respiratory problems that those patients can encounter through their lifelong.
Yeah, indeed.
So, Lino, we listen to you.
Okay, is again indeed the child that has been studying in our hospital with the multidisciplinary team. And okay, so you see the diagnosis was done with fetal ultrasound, that we were able to see the achondroplasia and also isolated megacisterna magna. Then the child spent a couple of days in the neonatal intensive care due to cyanosis, hypotonia, apneas, and also bradycardia. And we performed an MRI in the 5th day, and this MRI was showing a megacisterna magna and also a reduced amplitude of the foramen magnum with an altered CSF flowmetry. And also neuroradiology also saw some alteration at the level of the temporal region, kind of temporal mesial dysgeria. So this, after 1 month, there was a change in the neurological features of the patient. So the occurrence of pyramidal signs, that the clonus, although not constant, and the mild muscle hypertonia. So we repeated the MRI, and MRI was unaltered, so it was the same as at the 5th day. After a couple of months, he was hospitalized for the appearance of suspected sleep apnea, so he underwent an ENT evaluation, and there was a detection of laryngomalacia, and was proposed a surgery at that moment. However, so this is a more really general question. So there is a suspicion of sleep apnea. The ENT is showing, signaling some laryngomalacia. So what exam should you perform now at this moment? I think the answer is very clear. So I can go ahead if there are no comments on that. So we perform a polysomnographic examination. Indeed, we perform a full polysomnography, also because not really, also including EEG channels. And as you can see here, there was a severe respiratory disorder with more than 34 apneas per hour, mostly obstructive in nature, although there were some central sleep apnea. And also the oxygen desaturation index was very high. And you see here the desaturation were also very important. You can see here the hypnogram, and you can really appreciate the periodic occurrence of this important desaturation. In the middle of the night, we don't have apneas simply because we have lost the sensor from the abdominal and chest, so we only score the saturation. But here again is full of apnea. I want to underline this fact that if you look at snoring, sometimes it can happen that you have dramatic apneas, but you don't have snoring. So I think this is a very severe case. And if you look at the structure of sleep is not so much altered by the high number of apneas. So when you are so young, you don't have probably sufficient arousal threshold to have awakenings.
No, I'm sorry, but we just have 10 minutes left.
Yeah, I go very rapidly to the end. So
okay.
just a couple.
I'm sorry.
You see here, we have many apneas, but we don't have clear-cut arousal, this especially in REM sleep. So what treatment can we start here? Again, we started with CPAP treatment. because the parents were extremely worried about the surgical intervention. So they refused the surgical intervention. We start with CPAP, and the CPAP indeed induced a reduction in sleep apnea, although you can see that there is a persistence of sleep apnea, and there is even an increase of central sleep apnea, although the mean oxygen saturation is increased. So at 4 months, we observed a mild protrusion of the opistheon, and so the compression surgery was proposed. But again, the parents refused a surgical intervention, and so we decided to reevaluate the clinical picture after 3 months. And you see here that there was at the 5th month again a reduction of amplitude of the foramen magnum, and also worsening of pyramidal signs, hyperreflexia, irritability. So at this point, really, we discussed again with the multidisciplinary team and with the parents, and so we went towards the intervention. So the patient was submitted to the compression surgery, and there was a rapid improvement of neurological features and also in the behavior of the child. We perform again a polysomnographic recording during nocturnal CPAP that was maintained for pressure, and you see that there is still some apnea, although with a marked reduction of central and the persistence of some obstructive sleep apnea. So going back to what we were discussing before, now we perform a neurosurgical intervention, mostly for also with the aim of treating all the neurological aspects, including the central sleep apnea. But again, here probably the compression was able not only to favor the occurrence of central sleep apnea, but also obstructive apnea. So this, going back to what we were discussing before, an alteration of the central respiratory drive can even favor obstructive apneas, not only central one. So what can we do now? We have to monitor the evolution of the disorder. We maintain the CPAP treatment, and we will see what will happen in the future to this child that still is studied in our center.
Thank you very much. May I have the next slide, please? So first, before concluding, do you have some questions on the case presented by Lino?
Brigitte, there is one question in the chat function from Geert. Can you see that question?
I still have a general question to the panel of experts. We all agree we should screen for sleep disordered breathing, but the question is when and how in infants with achondroplasia before the age of first month, or rather later, with polysomnography or at home. If first evaluation is normal, need to repeat when and how. That's exactly the topic of this workshop. I think that within the first months of life is quite early. I think that the most general recommendation and guidelines recommend to do it around the age of 6 months, and at least before the age of 1 year. And if the diagnosis is made at the time of the diagnosis. Of course, polysomnography is the gold standard, but always difficult to obtain. So a respiratory polygraphy can be an alternative. However, a polysomnography or a polygraphy is not available, then a last solution would be pulse oximetry with transcranial CO2, but that will not give you any information on the type and the importance of the respiratory events. at home, I think that that depends on the type of center, but in France, in our institution, because of the underlying disease and the difficulty to have correct monitoring at home, we perform the studies in the hospital. I think which is possible for those children with rare, severe genetic disorders. And then the follow-up, I think we have sufficiently evidence to say that it's necessary to do regularly evaluation, whatever the symptoms of the signs, and mostly within the first years of life, because then you have the greatest risk of have associated factors of area obstruction, such as hypertrophy of the adenoids and the tonsils. For the next steps, a certificate of attendance will be sent to all the participants after the workshop. The survey slides will be available on our website. We will, after this workshop and after having analyzed all the questions and remark, developing a guiding principle for sleep disordered breathing. And also, could you please complete the evaluation question that will appear when the Zoom meeting ends.
Hey, Brigitte, just before we finish, Mickey, you had your hand up. Is there something you wanted to say?
I just commented in the chat because home sleep studies for children are not reimbursed in most of the countries, so very difficult to do. And the quality of home sleep studies is very often a problem. So we don't do sleep studies in children, and especially not in children with underlying disorders, because as Brigitte mentioned, the problems might be so complex that it's better to do this in a sleep center.
Okay, thank you. And there's also a comment from Sergio. I don't know if you can see that, Brigitte, if there's anything you'd like to reply.
No, I totally agree with Mieke.
Okay, and the comment from Sergio in the chat function. There's a message from Sergio saying, complementing the general guidelines, it would be helpful if there were a more detailed description in the paper by age group of the stepwise screening options and also of the treatment option recommendations, such as Brigitte explained.
That's great, Sergio. That's something that I will pick up with you as an author group as we go through the manuscript, but thank you for that. That's really helpful.
Okay, so I think it was a very, very dense meeting. It was really a challenge to speak about this very important topic in 3 hours, which is really, really very short. But the number of participants underlines the importance and the challenge of this question. So I would like to thank you all very, very much, and also the EAF team, which is a really extraordinary, efficient, and very nice team. So I thank you all very much. We are looking forward a nice paper, and also to continuing to work all together for patients with achondroplasia. Thank you so much.